Okay, guys, I'm going to start our session. So, welcome to the morning session of Clinical Epidemiology Unit and our short course in Clinical Epi. Today, we have a slightly interesting topic. It's guidelines. Guidelines are now the major part of any medical specialty. Everybody likes to do guideline-based treatments. So, how are the guidelines developed? And more importantly, we may never develop a guideline, but we'll definitely use, even statistics will use guidelines, medicine will use guidelines. In every branch, engineering, agriculture, veterinary, nursing, guidelines are used. So this tool which Mercy is going to take us through, the Agree tool, and she's going to use a rather new guideline on heart disease, is just to take us through the guideline process and what a good guideline should look like. Mercy has put a lot of effort into it, so we'll wish her the best, and I want to stand between you and a good feast.
Thank you, sir. Good morning. Welcome to another session of CEU. Today we'll be looking at critical appraisal of a clinical practice guideline. So, just another day in the emergency department. So we have a 65-year-old diabetic, hypertensive, reformed smoker presented to a tertiary care center with a chest pain, associated sweating and palpitations for 45 minutes. On examination, he had tachycardia, tachypnea, and a normal blood pressure. This is the ECG. We don't have anybody. But anyways, this shows an ST elevation in lead 2-3 areas consistent with an acute inferior wall MI. What do we do next? I would have offered him, given that he's come within 45 minutes to a tertiary care center, I would have offered a primary PCI. The next question is, what is the ideal choice of antiplatelet therapy? Aspirin plus ticagrelor or prasugrel, aspirin plus ticagrelor, clopidogrel, aspirin plus ticagrelor, aspirin plus clopidogrel. So now, how do we know which one to choose? So where do you get the answer from? So some of us will prefer to look at Davidson's, Harrison's, and Braunwald's. Others. So let's see if there's something new. So I just wanted to take you through this picture, which is called the evidence to the decision framework. Now we have a question in mind, which is what is the most ideal antiplatelet therapy in somebody with an acute coronary syndrome, which is a ST elevation MI, who's come to a tertiary care center within 45 minutes, and he's planned for a primary PCI. So now what is the choice of the antiplatelet therapy? So this is a question that we have in mind right now. So now we have identified the problem. So we can get a legend here. So we have policymakers, health and other professionals, patients and public, all of them involved in the question formulation. Now we are going to find out the answer to this question. In the process of finding answer to the question, we want to look at the benefits and harms of the option. First, we look at all the options that we have, benefits and harms of the options, values and balance efforts, resources required, cost effectiveness, equity, acceptability, feasibility. With all these things, these are the main core concepts of how we look at which is better than the other. Then you will look at all the studies that you have answering these particular questions in each of these domains. And at the end of that, you will have a judgment committee which will say which is better than the other. So now we know that we have evidence. A whole lot of people have come together and come to a consensus. So, and then we have recommendation 1, 2, and then there's a decision. And this recommendation will be a part of the guideline for a decision at the end of it. Sometimes it can be incorporated into the reports. So this is the evidence to the decision framework. So now what is a clinical practice guideline? So it is a systematically developed statement versus practitioner and patient decisions about appropriate healthcare for specific clinical circumstances. It plays an important role in health policy formation. It covers topics across healthcare continuum. So there's health promotion, screening, diagnosis, treatment, intervention. So for that, to answer the question that I previously asked, I've picked this article. This is the 2025 ACC/AHA guideline for the management of patients with acute coronary syndromes. So this is one of the from the guideline. And if I were to answer the question looking at these guidelines, the answer would be aspirin plus ticagrelor or prasugrel. So now why are we doing what we are doing? So our guidelines foolproof? Just like anything else, it's not. So the potential benefits of a guidelines are only as good as the quality of the guidelines themselves. So how do we attempt to assess or improve a guideline? So there is an appraisal of guidelines for research and evaluation 2 checklist. So this is the checklist that I will use to see how good or how bad the guideline that we had looked at is. So the agreed-to instrument was developed to address the issue of variability in guideline quality. It assesses the quality of the guideline, provides a methodological strategy for the development of guideline, inform what information and how information ought to be reported in the guidelines. So who can use the agreed-to tool? Healthcare providers. So own assessment of guideline before adopting into their practice, like all of us. Guideline developers, some of you. Rigorous development methodology, internal assessment of the guidelines and evaluate guidelines from other groups. Policy makers decide which guidelines could be recommended for use in practice or policy. Educators to enhance critical appraisal skills or teach core competencies in guideline development. Some of the things that I want to say is that the tool has not been designed to assess the quality of guidance documents that address healthcare organizational issues. Again, its role in the assessment of health technology assessments have also not been formally evaluated. Ideally, it needs to be assessed by at least 2 appraisers, preferably 4, but I'm going to do it alone. It does not include a not applicable response item in its scale. So you can do one of the 2 things, whether you can skip that question. If you skip that question, then your denominator also will also have to come by the number of questions that you skip. Or you can give 1, which is the lowest score that you can give. But it is advised that you give 1 as opposed to skipping the question. So what is the structure and the content of the tool? So this has 23 key items and they're organized into 6 domains. And there are 2 global rating items, the overall rating. The first one is called scope and purpose. It's the overall aim of the guidelines, specific health questions, and target population. It has 3 questions under this domain. The domain 2 is stakeholder involvement. Was the guideline developed by appropriate stakeholders and represents view of its intended users? Rigor of the development. Process used to gather and synthesize evidence, methods to formulate recommendations and update them. Clarity of the presentation deals with the language, structure, and format of the guideline. Applicability pertains to barriers or facilitators to implementation, improve uptake, resource implications of applying guidelines. Editorial independence, formulation of recommendations not biased with competing interests. After all this, there's an overall assessment that includes a rating of overall quality of guideline and whether the guideline would be recommended for use in practice. I mean, even if we do check all these 6 things and we feel that it is not, if we feel that we cannot apply it, then there is no point in having a guideline that people cannot apply to their patient in question. So we'll start the checklist now. So domain 1 is for the scope and purpose. It has 3 questions. So for every so it has scoring from 1 to 7. 7 is the best and 1 is the worst. Every time I score anything less than 7, I try to justify as to why I had scored it less than 7. The overall objective of the guideline is specifically described. So most of us are used to the CASP checklist, and CASP has these few tiny questions on the side, on the right side of the questionnaire to help us. I mean, they use as clues to score the questions. The CASP has only yes, no, maybe, but here it's even more objective, ranging from 1 to 7. So I had highlighted the most important things. So each question actually has the description manual, where to look in the body of the guideline, the main criteria for rating, and any additional considerations. So for this question, the overall objective of the guideline should be described in detail, and the expected health benefits from the guideline should be specific to the clinical problem or health topic. So they had also given some examples, preventing long-term complications of patients with diabetes, etc. So what are we supposed to look at? We look at the health index, whether it's prevention, screening, diagnosis, or treatment, what is the expected benefit or outcome, and who are the target people that we are looking at. So if the answer is yes to all of them, then it will be a 7. So this is from the abstract. So this is the snapshot from the paper itself. So it says aim is the 2025 guideline for management of patients with ACS incorporates new evidence from what was there in 2013 and what was there in 2014. So this for the management of patients with ACS, and 2021 for and retire and replace the previous ones. The guidelines focused updated duration of DAPT with coronary artery disease. So they could have had a clear section called objectives. I felt that the aim itself was pretty vague. They could have elaborated more on it. However, in another section, they had mentioned that this will focus on the acute management of ACS, including unstable angina, STEMI, which are presumed to result from an atherosclerotic plaque rupture, plaque erosion, subsequent thrombosis. So although I was not too happy with the way they had put the introductory slide, given that there was information in other part of the paper, I had rated them a 6. Next question, the health question covered by the guideline is specifically described. So here a detailed description of the health questions covered by the guideline should be provided, particularly for key recommendations. So target, intervention, comparison, outcome, healthcare setting or context, just like you do for a PICO. So for that, so these are the questions that they mentioned. Initial evaluation management, standard medical therapy, STEMI management, NSTEMI, catheterization laboratory considerations like PCI, cardiogenic shock, ACS complications in hospital issues, discharge and long-term plans, what are the gaps in future directions. So I had put strongly agree to this because they had managed to cover most of these that I would be interested to know also. So this is just a snapshot of all the things and each of them had smaller subtopics in it. The population to whom the guideline is meant to apply is specifically described. So here you talk about the target population, gender, age, clinical conditions, severity, staging, comorbidities, excluded population. For that, it was applicable to patients with or at risk of developing cardiovascular disease. This is what they had mentioned. But I felt that could have been more specific. It does not mention gender, age, comorbidities. If there are any specific group of people that they had excluded, it just said all those who are at risk of developing cardiovascular disease or who have developed a cardiovascular disease. So I had rated it a 5. The next domain is stakeholder involvement. This also has 3 questions. Under that, the guideline development group includes individuals from all relevant professional groups. So they say whether there's name, discipline, institution, geographical location, description of the members' role. So to answer that, the writing committee consisted of general cardiologists, interventional cardiologists, surgeons, critical care cardiologists, emergency physicians, radiologists, nurses, clinical pharmacists, and most importantly, patients and their representatives. They were all representatives from the AHA-ACC, the American College of Emergency Physicians, and the National Association of EMS Physicians, and radiological bodies. I felt they could have included policy makers, health economists, clinical administrators, and social scientists also. So I had given them a 5. Next question is the views and preferences of the target population have been sought. So essentially what they're saying is that if there was any mention of the type of strategy that we used to capture patients' views and preferences, participating in the guideline group literature review, methods by which these preferences and views were sought, and outcomes and information gathered on the patient, description how this information gathered was used. So it does not explicitly detail formal mechanisms for seeking the views of the public, but they did include patient representatives on the committee. They had shared decision making in selecting interventions based on individual values, preferences, associated conditions, comorbidities, their financial status. They also had a dialogue with the patients who have experienced an ACS event about secondary prevention and building self-care skills. But how did they go about doing this entire process was not described in it. It was not described in the paper itself. So I had rated them a low 3 here. The next is the target users of the guideline are clearly defined. So clear description of the intended guideline audience, specialists, family physicians, description of how the guideline will be used by its target audience. To answer that, the target users are practitioners and patients with or at risk of developing cardiovascular diseases who have for acute management of patients with ACS, all three together, unstable, STEMI, and STEMI. It was mentioned that it's focused on medical practice in the US, but it's also stated relevant to patients throughout the world. So I had rated a 7. The next domain is the rigor of development. So here there is a problem in the sense that firstly, the guideline does not come with a supplementary. Secondly, there was no mention of the methodology in the guidelines. They had like maybe about 3 paragraphs in total for me to answer all 8 questions with regards to the methodology. However, in one of the sections, it mentions that they have actually used the methodology manual and policies from the ACCH Task Force on Practice Guidelines. So this is published in 2010, and this is the guidelines that any paper that comes out of ACCH is expected to follow. So it is in future tense. So the only problem that we have with this is, although they're expected to follow this, we have no way to check whether they have actually not done it. I don't know if you can say if it is not documented, then it is not written. So if I were to go by that, then the entire section would have been to loss. But I assume that they had done whatever they could using this methodology. So this is from that paper, which is looking at the document develop process, select topic and writing committee, determine guideline scope, clinical objectives, determine writing assignments, sort, evaluate, and synthesize evidence, write the recommendations based on the interpretation, reach consensus. They would have probably used the Delphi technique here, create tables, diagrams, algorithms, valid recommendations during the writing, send draft document for peer review, respond to the peer review committee, comments, final writing, and then publishing. So it appears like, the entire process seems to be very ideal, but there is no way to check if this particular group, writing group and the peer group had actually used all of these things and followed this algorithm. So anyways, I will assume that they have used that, but I'm not marked them as 7 anyway. Next is systematic. First question in that is systematic methods were used to search for evidence. So we are expected to look at details of the strategy used to search for the evidence. So named electronic databases, time period search items used, and full search strategy included. So to answer that, the literature search was conducted from July 23 to April 24. They had identified clinical studies, systematic reviews, meta and other evidence. I thought they could have elaborated on what the other evidence conducted on human participants were. But the original methodology document actually mentions that they would use observational studies depending on how much evidence that they have. If they do not have interventional studies, they will go to observational studies, case report, expert opinions. They had used only English language, search through Medline, Embase, Cochrane Library, Agency for Healthcare Research and Quality. I felt they could have also included non-English literature, databases from other countries, unpublished data. They also did not mention citation tracking. So I rated them a 5 for this. So the next is systematic models were used to search for evidence. So they had key search words like HA, ACC, ACS, angina, anticoagulants, aspirin, so on and so forth. The studies were, so in addition, although the search had ended in April 2024 and they had started writing, the subsequent papers that were being published during the writing process were also included, which I thought was a good thing. They had focused on RCT but had included other types of study designs also. They had independent evidence review committees commissioned for unanswered questions. So essentially what they were looking at is so if they have a burning question that they did not find an answer to the question, so they had formed another independent team that would conduct a trial, provided that it will be done before the writing of this paper is over. So those are things like time-bound studies for which they're likely to develop an answer by the time the writing is over. So they had also reviewed previously published guidelines and related scientific statements. I felt that the keyword search was, although it appears like they had like about 16 to 17, we could have had like at least another 20, 30 to increase the search. So I had given them a 5. So these are the details of the previous papers that they have searched and incorporated into it, just that there's no duplication of work. The next question is, the criteria for selecting the evidence are clearly described. So description of the target population, study design, comparisons, outcomes, language, and context. So to answer this, they did not provide a Prisma flowchart, which I think is a big red flag. There was no mention of the inclusion and exclusion criteria, no mention of exact number of interventional or observational studies that were the number that was screened available and the number studied and incorporated into it. So for an example, it mentions that the cholesterol treatment trial meta-analysis of 5 RCTs shows that LDL concentration lowering with high intensity statin compared with moderate intensity statin reduces cardiovascular events by 15%. So I would have expected them to give me the inclusion criteria, exclusion criteria, number of patients, what was the outcome with the confidence interval and the confidence and the grade. So that would have been the most ideal way to present data. But anyways, they had reviewed previously published guidelines and related scientific statements. They didn't want to repeat. So in case they were incorporating older ones, they had it as one of the 2, which is modified, which is formatting changes, minor changes in the paper, or adapted, like substantiative changes, major adaptations such as the change in class of recommendation, level of evidence, drug or device classification. Although there are some red flags, I had given them a 3 because the only good thing is that they had given us the hyperlinks to all the papers that they were talking about. But just that we don't know if this is all the evidence that there is, or there is more to it. So I just two wise men's quotes. So it is important to err on the side of over-inclusion, because once a trial is has been excluded from the selection process, it is unlikely to be reconsidered. However, questionable articles which are included at one stage can be excluded at a later stage when more information on the study is available. The next is, because a guideline based on incomplete or biased evaluation literature can lead to inappropriate recommendation, the search for relevant research should be comprehensive. Research should be selected using explicit criteria, and validity of the results should be judged in rigorous and reproducible fashion. This is the reason why I thought I should rate low on the previous question. Next, the strengths and limitations of the body of evidence are clearly described. So here again, the study design, study methodology, including sampling, blinding, allocation, concealment, appropriateness and relevance of the primary, secondary outcome considered, consistency, direction of results, magnitude. So these are all the things that we need to take into account for rating this question. To answer this, this picture is from another guideline. This is from the European Neurological Society guideline on management of ALS. So this is how an ideal picture to answer this question should look like. The outcomes and absolute effect, relative effect, number of participants in the studies, certainty of evidence, and the comments on it. But however, what I have is this, which I had shown earlier, that there were 5 meta-analysis of 5 RCTs. No, I mean, in very superficial manner. So I had rated them a 3. The methods for formulating the recommendations are clearly described. So like I said, there was no mention of the methodology in the parent article itself. So here there is, most of it is around Delphi technique. So there's description. So what are the steps used in the modified Delphi technique, voting procedures that were considered, outcome of the recommendation development process, description how the process influenced the recommendations. But in the methodology document that was there, I mean, that they had mentioned that they had used, the steps were very clearly written, how the voting process would go on, how people were chosen for the voting process, how the writing committee cannot take part in the voting process, how the writing committee is different from the peer review committee. So all of them very, very clearly described. So because I'm assuming they've done this, I've given them a 4. The health benefits, side effects, and risks have been considered in formulating the recommendations. So here they want, so they want us to look at things like survival, quality of life, adverse effects, and symptom management or a discussion. Whether there is supporting data for any of these things. So to answer this, so they had used, they had mentioned the good thing is that they had mentioned the class of recommendation and the level of evidence for every single recommendation. So class of recommendation is essentially the strength of the recommendation, which encompasses the estimated magnitude, the certainty of benefit in proportion to the risk. It demonstrates the direct consideration of both the positive outcomes and the potential harms. Level of evidence is basically the amount of scientific evidence that is supporting the intervention based on the type and the quality of the evidence that we have. So they also had what is called a recommendation specific supportive test. Although they did not have the evidence to decision table that I had shown earlier. So they had the synopsis, they had a recommendation, synopsis, and supportive text, which I had shown earlier for each of the recommendations. So this is one of those. Several trials, again, like I said, it was very vague. Several trials have demonstrated the clinical benefit of oral P2Y12 inhibitors in ACS. In randomized placebo-controlled trials in both NSTEMI, STEMI, the addition of clopidogrel aspirin reduced risk of MACE. So it is very superficial as to what they mean by these words. So there's an explicit link between the recommendations and the supportive evidence. Again, the guideline describes how the guideline development group link and use the evidence to inform recommendations. To answer that, they had what is called a modular knowledge chunk format, which is different from the evidence to recommendation. A table of recommendations with COR and LOV is clearly indicated. They had a synopsis of the recommendation. They had a recommendation specific supportive test. And there are hyperlink references to the original research articles. They have also looked at updates based on the new evidence. So this ensures that recommendations are linked to the most current and relevant evidence. Having done all this, they could have easily provided us with an evidence to decision table. It's such a small thing to make. So anyways, I had rated them 5. The guideline has been externally reviewed by experts prior to its publication. Self-explanatory question. To answer this, so they had individuals that were nominated by the same organization that was making the guidelines. And the nominees from the same organization were also required for approval of the publication. Interestingly, they had only 2 appendices at the end of the guideline, and both of them were the names of the people in the writing committee and the peer review committee. I had actually cross-checked each of them, and there was no overlap, and they did not have any conflict of interest. So I had given them a 7. Next question is the procedure for updating the guideline provided? To answer that, so this is what it mentions about, roughly mentions about if they would do any updating. So they would have continuous reviews, updates, and modified guideline methodology on the basis of published standards and on the basis of internal evaluation. There will also be presentation, delivery of guidelines, modified in response to evolving technology and other factors. To ensure that guideline recommendations remain current, new data will be reviewed on an ongoing basis. But the question, I mean, in the key question, it asks us if there was time period that was mentioned or how they would go about doing it. Although they said they will do it, but how they will do it, when they will do it is not there. So they did not mention explicit time interval or the criteria to guide decisions about when an update will occur or the methodology for the updating procedure. So I'll give them a 3. So that brings to, I don't know if I was being very cynical about the methodological section, but that is the one which I felt was like least performing in all the domains. So the next one is called clarity of presentation. So the first one in this, the recommendations are specific and unambiguous. To answer this, they had a modular knowledge chunk format, which I had gone through earlier. I had just put one example. So it said in patients with suspected ACS, a 12-lead ECG should be required and interpreted within 10 minutes of first medical contact to identify patient with STEMI. So here the recommendation specifies the patient group, which is a suspected ACS, the action, which is 12-lead ECG acquisition and interpretation, the time frame, which is 10 minutes, and the goal, which is to identify the STEMI. So the only problem I had is that it does not mention specific caveats, like specific population groups. There was a section on anticoagulation. So let's say we have pregnant women with anticoagulation. Would we do it any different from other people? So I've given them the 6. So this is just an example of, to show that the the way it was presented is quite clear. It's the same thing that I had shown in the beginning. The different options for management of the conditions on health issue are clearly presented. So essentially, we are looking at, for a problem, are all the options that are available mentioned here. For a given problem, are all populations addressed? So they had mentioned, they had looked at antiplatelet therapy across different groups. They had looked at different strategies for revascularization. So I had given them a 7. So this is just an example to show how they're given. So routine invasive versus selective invasive strategy in patients with non-ST elevation MI. The high or intermediate risk STEMI based on the Gray score will have routine invasive strategy. The low risk will have either the routine invasive or selective invasive. And after the non-invasive risk stratification based on the CT and calcium scoring or stress testing, they will do an angio or PCI CABG, different revascularization techniques. So key recommendations are easily identified. So the document actually begins with top take-home messages, clearly described. So I had given them a 7. The next domain is applicability. There are 4 questions under this. The guideline describes facilitators and barriers to this application. Essentially, to identify what can cause these guidelines to be being acceptable in a situation, or what can cause for it to not being acceptable in a given situation. So they had mentioned things like feedback from key stakeholders, pilot testing. So what do we do? How do they get this information, and what do we do with the information that we get from here? So for that, some of the facilitators that they have mentioned were clinical decision pathways. So it is good that in the guidelines I have mentioned that you can modify the guidelines to suit your own geographical area. So that is the clinical decision pathways. Shared decision making is engaging the patients in selecting the intervention based on their financial needs, comorbidities, etc. Innovative models of care. They had, for example, they had tried to incorporate home-based and hybrid cardiac rehabilitation, public education, looking at social determinants of health. So addressing all these things would facilitate the uptake of the guideline. The barriers, most importantly for a third world country like us, would be cost of medication and treatment, accessibility of intervention, system level issues like if we were to have a PCI center at every village, that is having to have people at every village, patient related factors. So they may be a pharmacological difference in clopidogrel resistance between different groups of people, variable responses to therapy. So, like I said, it does not mention the methods by which information regarding the facilitators and barriers to implementing recommendations sought. So they mentioned these were the problems and the good things, but how did they identify this and how are they going to address this is not mentioned. So I'd given them a 5. The guideline provides advice or tools on how the recommendations can be put into practice. So essentially looking at guideline summary documents linked to checklists, algorithms, manuals. To answer that, so they had it was to begin with, it was structured to facilitate application at the point of care. They had used something called teach back technique. So when they had patient education at the end of their hospital stay, the patients were asked to say what they were taught, just to emphasize that they have actually understood. They had multiple educational tools, clinical decision pathways, like I have mentioned earlier. So they could have done a pilot testing to see how good or bad the uptake of was. So I had marked them a 5. The next is the potential resource implications of applying the recommendations have been considered. So this year, most of the things is about how have we considered cost at all. So to answer that, they had mentioned cost a lot of times. So cost value considerations are recognized as important, but there was no mention of formal assessment. We do not know. I mean, they could have easily taken an example of one drug being 10 rupees, 20 rupees and compare or things like that. So they had mentioned that with regards to a microaxial low pump for cardiogenic shock, they mentioned that there was benefit in reducing the mortality, but it was too expensive for anybody to be able to use it. Same thing was with statins, that the higher the dose, the more expensive it is, and that itself had stopped people from taking it up. And cardiac rehabilitation. Cardiac rehabilitation in the sense of availability and resource setting. So it does not explicitly state whether a health economist was part of the guideline development panel. So I had given them a 4. So the guideline presents monitoring and auditing criteria. This is to see identification of criteria to assess guideline implementation or adherence to what was being said in the guideline. So the guideline presents monitoring or auditing criteria. So something like I have showed you an example. It says that any patient who comes with chest pain have to have a ECG done and read in the next 10 minutes to have to diagnose STEMI. So that was one. So the 10 minutes can be used as an audit. Although they did not have this auditing criteria across, so they do not dedicate a specific section solely to monitoring auditing. But some of these points did have something that could be used as an auditing criteria. So I had given a 4. The last section, the views of the funding body may not have influenced the content of the deadline. So it mentions that the ACCIHS sponsored the development and publication of the guidelines without any commercial support. They include appendices detailing the relationships with industry of both the writing committee members and peer review committee. Last question is competing interests of a guideline development group members have been recorded and addressed. Writing committee members were required to recuse themselves from voting on sections to which their specific relationship with industry may apply. So in fact, they had given them what it means to be related to the industry. So it says a person is deemed to have significant interest in business if the interest represents ownership of more than 5% of the voting stock or share of the business entity or ownership of more than $5,000 of the fair market value. So if you have any of these, then there is a potential conflict of interest and then you will have to be out of this. So I've given them a 7 for that. I felt this was quite clear about transparent. They had about 12 to 15 writing committee members. So this is just to show where their employment, consultants, speakers, ownership, partnership, personal research, expert witness. So most of them did not have any conflict of interest, and they're all working in educational institutes. So in summary, this is how I had rated them on domain 1 to 6 and across questions. So we finished the first part, which is rating the guideline on each domain. The next is the overall global rating. So this is the domain score calculation. Ideally, you need to have 4 appraisers. For us, it is just 1 appraiser. And you will get this domain score by doing this obtained score minus minimum score, by maximum minus minimum. So I had done that for each of these domains. Like you can see, and like what we have also looked at, the third domain had done fairly bad. It has obtained a score of 35 on the maximum score of 56. So the domain score is 56.2%. So the overall guideline assessment, I had given a 5. I had done the total score. I had taken a mean, basically the total score by the number of questions, 23, which had come to 5.2. So I had given a 5. So would I recommend this guideline for use? Yes, with modifications. So now that I have appraised this, I also thought this is my duty to tell you what is there in the guideline, not just say that they have not done what they're supposed to do. So I thought for the benefit of the house, I will take you through the top 9 take-home messages. The first thing is with regards to DAPT. It is recommended for patients with ACS. Ticagrelor or prasugrel is recommended in preference to clopidogrel for undergoing PCS. That would answer our first question. In patients with NSTEMI who are scheduled for invasive strategy with timing of angio more than 24 hours, upstream treatment with clopidogrel, ticagrelor may be considered. Second is DAPT with aspirin and an oral P2Y12 inhibitor is indicated for at least 12 months as the default strategy, bearing in mind that they do not have a high bleeding risk. Several strategies available to reduce bleeding. One thing is to give them PPI so that there is no GI bleed. In patients who have tolerated DAPT with ticagrelor, transition to ticagrelor monotherapy is recommended 1 month after the PCI. Aspirin discontinuation is recommended 1 to 4 weeks after PCI with continued P2Y12 inhibitor, clopidogrel. So the third one is with regards to lipid lowering therapy. High intensity statin therapy is recommended for all patients with ACA with an option to initiate concurrent ezetimibe. We don't have to wait for 3 months before we add on ezetimibe. A non-static lipid lowering therapy like ezetimibe, PCSK9 inhibitors, inclisiran, bempedoic acid is recommended for patients already on maximum tolerated statin and whose LDL is more than 70. It is reasonable to use this highest population to further intensify the LDL cutoff to less than 70. The next one is in patients with NSTEMI who are at intermediate or high risk of ischemic events. An invasive approach with the intent to proceed with revascularization is good during the hospital admission. In patients with NSTEMI who are at low risk, so intermediate and high risk, you do it during the same admission, but if they're at low risk, you can do it at a later date. So 2 procedural strategies are recommended in patients with ACS who are undergoing PCI. A radial approach is preferred over femoral approach to avoid bleeding. Intracoronary imaging is recommended. The strategy of complete revascularization is recommended in those with STEMI or NSTEMI. The choice of revascularization should be based on the complexity. PC of significant non-culprit stenosis of patients for STEMI can be performed in a single procedure or stage, with some preference towards perform multi-vessel PCI in a single procedure. In patients with ACS and cardiogenic shock, emergency revascularization of the culprit vessel is indicated. However, routine PCI of non-infarct related arteries is not recommended. Based on one trial, use of microaxial flow pump in patients with cardiogenic shock related to acute MI is reasonable to reduce deaths. Cost is a big consideration for this. However, complications such as bleeding, limb ischemia, renal failure are higher for those who use it. Therefore, careful attention to vascular access and meaning of support is important. Blood red cell transfusion to maintain hemoglobin of 10 may be reasonable in patients with ACS who are not actively bleeding. At the end, after discharge, focus on secondary prevention is fundamental. A lipid profile is recommended 4 to 8 weeks after initiating or adjusting the dose. Refer them to a cardiac rehabilitation. So how would we resolve the case that we began with? For those who didn't come, okay, so we had an elderly man with all atherosclerotic risk factors who's come with an acute inferior wall STEMI being planned for a primary PCI. And we were wondering what the ideal choice of antiplatelet therapy is. So from the guidelines, we figure out that this is the answer. But having said that, is that what we would do? So I just put the costs here. If you were to use aspirin plus ticagrelor or prasugrel, this is for 1 month. So that would be about, if you're using prasugrel, it would come to about 1,140 rupees. If you're using ticagrelor, it will come up to 622 rupees per month. Normally, what we end up doing at this point in time is about 200 rupees. So to answer that, patients should receive care based on the best available scientific knowledge. Care should not vary illogically being the key word from clinician to clinician or place to place. But also bear in mind that evidence-based practice is integration of the best research that's available with the expertise that we have and the patient value. If we give him for 2 months and then he's lost to follow-up, if we give the best option for 2 months and then he does not come back after that, then we've lost the battle. So this is for those of us who are interested to in making guidelines. So this is Magic Cap. So this is an it's a guideline platform that facilitates development, updating, and dissemination. So it does not have any website. So what we are to do is you put in the individual study, the descriptive tables that are already there, evidence profile. You mention the pie chart, recommendations, key information, rationale, all in the database. At the end of that, you will get multi-layered formats. Multi-layered formats is you can either just choose to read just the abstract, or you press on the abstract and then you will get the pie chart, you will get what was the outcome and what was the level of recommendation. That same thing can be integrated into the EMR. So you have this, if you have this thing incorporated into our workstation, where once the ECG is done itself, and then there will be a pop-up, it says, hey, call cath lab. And then once that is come, and then it will open up the e-pharmacy and say, order aspirin plus ticagrelor, it's something like that. So it can be adapted into the national and local or EBM textbooks. And this will also be, it can be made available into an app for patients and the clinician to decide the next thing. So thank you. This is my last slide. Visit our channel for more videos. Thank you.